So
Okay.
I will try to control it, and if it doesn't work,
Yeah, I'm going to do the first 2 slides, and then we'll take it from there. All right, I'm going to start opening it up. Let people.
Remember, you've got the recording.
It's
You have that set?
Yeah.
Okay.
Okay.
And mention Neurocrine.
Yeah. All right, so people are filtering in.
Oh, it's interesting, folks. I have a little thing that says you can control your screen. So it says that I can control it now.
Okay,
I didn't
good.
realize that. That's a good notification to see.
Yeah. So do you guys see all of us on the bottom? Is that, or do you see?
I have you on the side, but
Okay, so that's something you control, right? Okay. Welcome, everyone. I'm going to give it just another minute for other folks to filter in. All right, let's go ahead and get started. Welcome, everyone. I'm so glad you're with us tonight. My name is Gabi Conacher, and I am president and co-founder of Wishes for Elliot. Which Deep Connections is a project, and Deep Connections is a collaborative effort among over 25 patient advocacy groups to help bring resources to families who have children with severe epilepsy and DEE. So welcome to our webinar tonight about saving our telehealth. And this is an issue that is really critical right now. I think a lot of us have found that life has changed urgently, very quickly, in the face of COVID. Before this, we were told, oh, there's no way we could ever do telehealth. It just won't happen. And somehow it happened very quickly. And our guests today are going to talk to us a little bit more about that. So we're really excited to help you better understand it, and then hopefully take some action to ensure that we retain access to this kind of remote care. And I forgot to also say that I am the parent of a child who has a DEE, 7-year-old Elliot. So this has also been really important for me during this time to gain access to our clinicians. So a couple of quick housekeeping things. All of the participants will be on mute throughout, and the only videos that will be on are those of the presenters and the panelists. Please put your questions into the Q&A box throughout as they come up, and we'll be monitoring that. And let's see, just a quick thank you to our sponsor, Neurocrine, who is really a fantastic group who's helping us to bring some of this critical information to all of you. So I will quickly just say that the moderator for today is Jayetta Hecker. She is the executive director and co-founder of Wishes for Elliot and Deep Connections, and she brings over 30 years of experience in policy and analysis and leadership. So, and she's been very engaged in the telehealth movement. So, Dr. Busis, off to you.
let's see now. Well, thank you very much for inviting me. I'm going to start this session by giving a broad overview of telehealth. And then Dr. Herman and Ms. Nikrand will take deeper dives into epilepsy and advocacy. So telehealth is from the Greek word tele, which is far, and health. And while we usually think of telehealth as audio-visual, two-way interactive, real-time visits. As you can see, there are really 5 buckets of telehealth services that are being used today. The simplest one is telephone. And in fact, the very first telehealth visit was a telephone visit when Alexander Graham Bell called Mr. Watson, said, "Mr. Watson, come here, I need you." It's because he poured sulfuric acid on his clothes. So that was actually the very first telehealth visit. There's also digital evaluation and management services, which is basically sharing data, not necessarily seeing the patient on screen, but sharing their data in an asynchronous way. I send you a picture or an EEG tracing or some labs, look at it, get feedback. Then there's the audio video synchronous real-time two-way communication, which is what we usually think of as telemedicine, which is the most commonly used modality. But there's also interprofessional consultations. In other words, I as a consultant or a primary care doctor speak with another primary care doctor or a consultant about a patient. The patient doesn't necessarily have to be there. And there's also remote monitoring. The most common use of that right now, for example, is blood glucoses for patients with diabetes, but one can imagine remote monitoring for a number of other physiological parameters. You know, Jay, I think it's probably best if you control because I'm having a lag. Yeah, let's go. Okay, this is fine. So there are 5 senses: eyes, ears, touch, smell, and taste. We don't really use smell and taste so much now. And we can substitute for 2 of the 3 senses very well in a real-time audio and video visit. So we have a high-quality webcam on both ends. Funny thing that the mobile devices such as iPhones, Android phones actually have much, much better cameras than laptops and desktops, by the way. And that's why we prefer them for use at NYU in terms of telehealth encounters. Next slide. We can substitute ears for speakerphones, either the built-in speakers and microphones that are on your computer or your mobile device, or extra add-on rigs such as this one. This is the actual one that we used at UPMC when I was there until recently. Next slide. The thing that we're missing is robot arms. There are no robot arms I know of that come out of people's iPhones right now. And so that is a limitation on certain types of examinations. Certainly it's not a limitation for the history and for the general appearance of the patient and their behavior and movements, but if you want to do detailed strength testing or sensory testing, etc., or if you want to see someone walk and you want to make sure they're safe, you either need an assistant on site or you have the patient try to examine themselves and either not walk or walk in a safe environment near furniture. Next slide. We usually think of telehealth as breaking down barriers to access. So for example, if you are far away from the provider, you want to see an expert in a certain condition, etc. If you have mobility problems, transportation problems, if you can't take time off from work, if you have other caregiver responsibilities, they break down barriers to access because you can connect, do the visit, disconnect without traveling, parking, waiting in the waiting room, etc. But as the next slide will show you, next slide, in the COVID era, we realized that telehealth is the ultimate personal protective equipment. The only virus that I can give you folks is a computer virus through this computer. I can't give you corona or anything else. And so telehealth is kind of interesting that way. It puts up certain kinds of barriers that we need today, but breaks down access in ways that we need even when there's not a pandemic. Next slide. Telehealth has had a very prolonged gestation. The first telephone call was in 1876, and even in the 1920s, they were writing about doctor visits by radio and then television, et cetera, et cetera. And people really wanted it. This is from Jessica, who was kind enough to share her slides. A 2017 study, patients wanted telehealth for a long time before insurers wanted to cover it. It empowered patients because it decreased barriers to access, instant access to care, instant access to information, convenience, and lower costs. You don't have to pay for parking and childcare, et cetera, et cetera. Next slide. There were profound barriers before COVID, however. Most insurances did not cover telehealth, and if they did, they had severe restrictions, which we'll talk about in the next slide. I'm not ready for it yet. There are data and privacy concerns. Some people feel very uncomfortable about sharing personal data digitally. There's also issues of technology literacy and the digital divide. NYU is using a direct-to-consumer model of telehealth, which is one of the kinds around there, which means that we connect with you via your mobile device. If you don't have a capable mobile device, or you don't have good broadband, or you have a very expensive data plan, you can't participate in an audio and video visit. We found, by the way, that telephone visits work nearly as well for certain things, but some people may not even have a phone. For telehealth providers that want to provide these services in multiple states, there's state-by-state licensure, except for the relatively few states that have an intrastate medical licensure compact, and their liability issues. The site of service is defined as where the patient is, not where the provider is. So that if I see somebody in New Jersey from New York, I have to have some sort of New Jersey license. And then, as I showed you with the little human hand and the robot hand, there are some barriers to physical examination. We can actually do pretty well in neurology, and we published a paper about that recently, with one exception. Right now, there is no really good way for most people to do a fundoscopy examination. There used to be a little attachment that went on iPhones, but they stopped making it when they switched from iPhone 8. I think it's because the cameras got so complex that this little clip-on no longer worked. So the only thing we absolutely can't do is fundoscopy, but we can do almost everything else, certainly with an assistant who's been instructed. Next slide. So to summarize the big changes in telehealth regulations that made telehealth possible today, this is also cribbed shamelessly from Jessica. Pre-pandemic, the sites of service were very restricted. They usually excluded the patient's home. So think about this. You're supposed to connect with somebody remotely, but you got to be at some office or at some hospital or some kiosk or something. That sort of doesn't make sense. There was very spotty payer coverage for telehealth encounters. Interestingly enough, Medicaid actually did more telehealth than anybody, and then Medicare and then the private payers were pretty restrictive. Telephone visits, if they were covered at all, were covered at a lower rate than video visits for established patients. Medicaid, once again, led the way in terms of covering for phone visits. And video appointments had to use HIPAA-compliant technology. During the pandemic, there has been a dramatic relaxation and opening up and expansion of telehealth. So now people can receive care where they live, not where the provider works. You can now be seen in your home, which is actually great, and others will talk about the advantage of that. There are greatly expanded service, not only physician service, but physical therapy and all sorts of other things. We have an incredible rehab program at NYU with all sorts of services that can be done virtually. And there have been relaxations in HIPAA compliance requirements. So basically things like FaceTime or Skype can be used there are still some programs that can't be used. The public-facing ones like FaceTime, you're not gonna, like Facebook, I mean, you're not gonna have a Facebook chat with your doctor, but FaceTime, Skype, and things like that can be used. And post-pandemic, we don't know. Now, we're going to have imminently a clue of what Medicare wants to do, because CMS, the Centers for Medicare and Medicaid Services, release a notice of proposed rulemaking every July. That's a preview of what their Medicare fee schedule for the following year is, which is usually published in late October and November. And any day now, they should release the 2021 proposed rule for the Medicare physician fee schedule. And we very much expect that they will have information in there about what they want to do about telehealth, at least for Medicare. We don't know yet, but we expect that. And they've been giving us lots of hints that they want to continue it. But once again, the devil's in the details. And also, of course, although as goes Medicare, usually the other payers follow, that's not necessarily the case. So that's what I had to say, and we'll transition over to Dr. Herman.
Oops, sorry about that. I'm an epilepsy specialist at Barrow Neurological Institute in Phoenix, Arizona. I'm also the president of the National Association of Epilepsy Centers, which has members of 257 epilepsy centers around the country. And I'm also the leader of the clinical core of the Epilepsy Learning Healthcare System. And I'm bringing that up because a lot of the information I'm going to talk about today was developed on behalf of either NAEC or the Epilepsy Learning Healthcare System. And I'm going to take over from, from where Dr. Busis discussed sort of the general parameters about telemedicine to how we actually made the transition to telemedicine and what lessons we have learned that may help us to sustain telemedicine in the future. I can tell you that at our institution, I've only been at Barrow since October, but one of my colleagues had been working on developing telemedicine there for 2 years and had not even gotten approval from the hospital to select a telemedicine vendor at the time that we began doing telemedicine visits. So I'm really going to focus today on 2 different kinds of visits, the video and audio visits, which can now be done in outpatient clinics as well as in the hospital and in emergency rooms. And then phone visits, which really are only a feasible method of telemedicine during this COVID emergency. Although much can be done over telephone, I don't think it's necessarily a substitute for ongoing healthcare. So the first thing that we did back when we switched over to telemedicine and, we're looking at how centers in NAEC were responding to the COVID emergency, we sent out a survey. This was done to middle to end of March 2020. And one of the areas that we were asking our centers about is, what is your experience with telemedicine? How are you doing telemedicine now? And what is your preliminary experience? So you can see here in this top graph that before COVID, more than 80% of centers had little to no telemedicine experience. Nearly 50% of centers had either no telemedicine or were what we were doing at Barrow, which was just starting to explore or test telemedicine. Some centers were doing limited use, less than 10% of their visits, and there were actually only about 15% of centers that were doing telemedicine, using telemedicine as a routine part of their practice. Despite that, within about 2 weeks of shutting down practices, most centers were using telemedicine solutions for nearly all of their visits. And I didn't put the data on here, but most people were doing greater than 75% of all of their visits by telemedicine. And interestingly, they really weren't using solutions that had been developed for electronic medical records or things that had been companies that had sprung up to do telemedicine. most hospitals were using things like Zoom and GoToMeeting and other commercial sort of video conferencing applications that were not specifically designed for healthcare. And that provided some flexibility, but also created some significant barriers to getting the system up and running. And at the time that we did this survey, which had 99 of the 257 epilepsy centers respond, most people, as I said before, 70% were using live video. Another group was doing audio only a small proportion were doing sort of portal communications where they were sending records back and forth with patients over email or patient portals, etc. So this is the timeline of what we did at Barrow Neurological Institute. So on Wednesday, March 11th, we actually closed our clinic and we went almost entirely to phone visits. We had 0% video visits at that time. We didn't even have a contract to do telemedicine. We signed a contract on Friday the 20th. We developed a task force to do Zoom visits, and we started Zoom visits on Monday the 23rd in epilepsy and movement disorders. And then over the next week, actually brought Zoom on board for many of the other groups in our neurology department. By the 31st, we had actually set up our information technology group, set up what they called tech training, where they would contact patients before the visit and help them set up their Zoom systems, their devices, in order to be able to do the video visit because it wasn't integrated into our medical systems. And then by the 3rd of April, all providers and staff, all the medical assistants, et cetera, were trained to do telemedicine. And by the 16th, we were doing more than 80% of our usual clinic volume on Zoom. So less than a month when we had been trying to do telemedicine for 2 years. You can imagine that this took a lot of people. So this was our telemedicine task force, and it included people from information technology who both set up the Zoom system, made sure that it was secure, made sure that it had the appropriate privacy protections. You remember that people were, publishing lots of information about Zoom bombing, so we had to make modifications to our system so that it was safe and secure for patients to have medical visits. We had a group of people doing tech checks and working with patients to have successful Zoom visits. We had a whole group of people in our clinic who were working with our medical assistants and the front desk staff, as well as the billing staff, to make sure that we could do these visits, schedule them, and then get paid for doing them. And then we had a whole group training physicians how to do telemedicine exams, how to document appropriately for telemedicine, and then teaching our residents and our fellows who had never done a telemedicine visit how to do it. This was definitely a case of, see one, do one, teach one, because most of us had not done any telemedicine either. One of the things that we did early on was develop a telemedicine visit checklist. So this was a list of things that patients could do to prepare for a virtual visit. And we shared this with groups of patients in the Epilepsy Learning Healthcare System to see how useful it was, and to give feedback on other things that patients thought that we should include. And this is now available through the Epilepsy Foundation, Epilepsy Learning Healthcare System. I put the web address at the bottom, so you can go and get this. It's available in English and in Spanish, and it just goes over some things that patients should think about as they're preparing for their telemedicine visits. This is what occurred in our epilepsy clinic. We were very interested in tracking how telemedicine went and in improving our processes. So again, through the Epilepsy Learning Healthcare System, we do something called PDSA cycles, Plan, Do, Study, Act, which meant that we would try something with a small number of patients. If it worked, we would keep doing it. If it didn't work, we would adjust our methods and try again, tracking information continuously. So this is a graph that shows our telemedicine visits from the 16th of March all the way through the end of April. You can see here that Initially, we had a significant drop in our patient volume from nearly 100 patients a week to about 60 patients a week when we went to telephone. We then went up to combined telephone and video visits. When we went completely to video visits, we again had a drop. But then interestingly, we were able to do successful video visits and actually were about 50% over our typical volume of visits. It turned out that it's actually much more efficient to do video visits. You know, the patient's there when you're ready for them. You don't have to move from room to room. You don't have to clean your equipment in between patients. And we had a lot of physicians who weren't doing other things in the hospital, so they were available to do more video visits. So we actually were able to increase our volume by 50%. And when we think about issues like access to care, being able to increase the availability of specialists in epilepsy is a really important factor. So you can see down here at the bottom, the percent of visits that we completed as telemedicine video was 94% by the end of April. We also tracked how patients and their families were using telemedicine and what devices they were using. So most people were using their computers. Another large group were using mobile phones. Some were using iPads, and then a smattering of other devices. And this is really important because it helps us to really look at the capacity of telemedicine going forward. But there were some concerns. So this is a snapshot of demographics for a month of clinic before COVID and a month of clinic afterwards. And you can see here that the proportion of patients, our underserved patients, largely Latino Hispanic population, decreased significantly during the COVID period because we probably are not being successful in reaching out to them by email, by English phone messages, to tell them about the fact that we're open and doing telemedicine visits, and they may not have devices. We also have a lot of American Indian population, and many of them are in remote areas and don't have access to broadband internet or devices. And then finally, you can see here from COVID compared to pre-COVID, that our older patients actually were much less well represented in this group. So we're not meeting the needs of some of our patient populations, and this is something that we need to pay attention to going forward. Now, sadly, we did another telemedicine survey. This is actually still an open survey, so these are just preliminary responses. 37 epilepsy centers have responded so far. And then this is the distribution of both video visits in the dark purple and phone visits in the light purple. And you can see now that more than 50% of centers are doing less than half of their visits by telemedicine. So this was a rapid rollout and now a rapid rollback of telemedicine, which I think is an area of significant concern and something that we need to work on very aggressively to maintain the opportunity for telemedicine. So in summary, telemedicine visits are feasible for providers and satisfactory for many patients. There's some concerns about equity, limited devices, limited broadband, unfamiliarity with technology, and unfortunately, a major driver of telemedicine is hospital and clinic administration concerns about reimbursement and actually having providers move back to in-person visits from telemedicine, sometimes even in areas that are fairly hotspots for COVID. So I will stop at this point. I will thank my entire group who worked on this, my Barrow team, as well as the National Association of Epilepsy Centers and all of my colleagues in the Epilepsy Learning Healthcare System. Thank you. I'm going to turn this over now to Jessica.
Hey, thanks so much. Hi, as was said, my name is Jessica Nickeran. I work at the Child Neurology Foundation, which is a nonprofit focused to, as you might imagine, child neurology education and advocacy. at this organization, I focus primarily on two different programs. One has been established for a while, transitions of care programming, which means that I help to empower youth and young adults and their families transition from pediatric neurology care to adult neurology care. And my other program that I'm overseeing now is Telehealth, which is a bit newer for us. As you've heard Dr. Busis and Dr. Herman speak about, the landscape's a little bit different now than it was even maybe 6 or 7 months ago. And so I am going to build on what Dr. Busis and Dr. Herman have said and talk about how you as a caregiver and parent can advocate to continue telehealth, because the environment right now is a lot more fragile than I think a lot of us realize it might be. So as we heard though from Dr. Herman particularly, there are some issues with telehealth still. Obviously, there needs to be more equitable access to the technologies that make telehealth possible. There are still issues with it not quite being a one-for-one. Telehealth isn't a substitute completely for care. But there are some things that really make telehealth more convenient for parents and caregivers. What we're hearing from our community, particularly in the child neurology space, is that in a lot of cases, it's increasing their access to care by lowering wait times. Dr. Herman spoke about how much more efficient these telehealth visits are. You can fit more in a day. So rather than calling and waiting 6 months for a visit, sometimes you can get in the same day. And higher access to care. In our community, as we all know, there's a lot of rare diseases. And you might live in the middle of Idaho, but the specialist for your child's condition lives in Dayton, Ohio. What do you do? Telehealth is empowering patients and their families to get in contact with those specialists for those rare diseases that affect so many of us in the child neurology world, and it's really being transformational in that way. We're also hearing from parents and caregivers that in a lot of cases, they find that their child's behavior regulation is improved during telehealth visits because there's less dysregulation. There's not an attempt to get somebody in the car, sometimes get them in a particular seat, either, in the car, and then find a place to park, drive a long way, prepare for hours before you even get to the visit. And then you're in this sterile and foreign place that might contribute to greater dysregulation on the part of your child. When the visit is taking place in your home, you can, bring the child to the screen, you can have the conversation, the provider can do the visit, and then, if your child wants to go play, you can then talk to your child's provider for longer, which is, I think, what a lot of parents and caregivers report is the bulk of their child's visit. Another benefit we're hearing from parents and caregivers is that having these visits inside the home helps to troubleshoot accessibility issues. So if you've been going to your provider and telling them that there's this really high step that is really difficult to manage for your child, or you want to help them figure out how to take a shower independently, or whatever the issue might be, you can actually take your device and show your provider the issue that you're trying to solve. And you can actually then, that provider can help to empower you to solve those issues in your home, rather than getting back to your house and saying, well, I think he said, this is going on. I can't quite remember. And so these are the three things that we've been hearing from parents and caregivers over and over again about why they would like to see the relaxed regulations that are currently resulting in increased telehealth visits now continue beyond the COVID period. And so what I mean by that is that the reason why we are in the environment that we currently are in due to COVID is because the Department of Health and Human Services, which is the federal arm that oversees almost everything in healthcare policy in the United States, declared a public health emergency earlier this year. And as there's a lot of different COVID-related parts of that public health emergency, but the part that relates to telehealth that really set things off for us in this area is that they relaxed HIPAA regulations, so the privacy regulations. And so what that did, and both Dr. Herman and Dr. Busis spoke on this, is that it really expanded the ways that you can access telehealth. You can FaceTime now. You can get a traditional Zoom account. It really helped to create more accessibility in that particular area. And in doing so, once those floodgates kind of opened, then payers followed suit, and we found ways to pay for this telehealth because this was the first barrier to making it happen had been relaxed. And so Dr. Buses, I think, was the one that mentioned that we follow, even though we're talking the child neurology community, we still follow Medicare because oftentimes Medicare will set this, I don't want to say set the standard, but sometimes sets the trends for how other insurers pay. However, when you're looking at the child neurology community, if you are on a public insurer, it's most likely Medicaid. And if you're looking at whether or not you are covered for telehealth, you very probably are. Medicaid, though, unlike Medicare, varies from state to state. So we can't just universally say, yes, it's covered, don't ask questions, go forth and access as much as you need. But there's been a lot of advocacy at the federal level to make Medicaid more likely to cover more broadly, including even the vice president saying that this is one of their priorities, and that I don't have more details for you from that. Hopefully we will soon, but it looks promising that these public insurers will continue coverage. But again, it varies from state to state. That said, your private insurers are also likely covered for now. Several of the big private payers that we know, Aetna, Cigna, Blue Cross Blue Shield, have said that they are making attempts to make telehealth more widely covered. Again, this is a state-by-state thing, though. Even though it's a private insurer, your state legislature can still say, we want our whole state to cover telehealth in this particular area. For example, Montana offers full coverage for private insurers. But again, I don't want to oversell the coverage, and so it's always best to do your research in your particular state. A really accessible and easy way to do that, and once the slide progresses, we can see a screen from the State Action Resource Center, from the Center for Connected Health Policy, from the National Telehealth Policy Resource Center. And that's a mouthful, admittedly. However, if you go to this site that I have linked here, the cchpca.org, and then COVID-related state actions, what you will see is a screen, and then there will be a drop-down on your state. I live in Minnesota, so I clicked Minnesota, and then you can see it has the agency and the emergency action that has come into play. It's color-coded so that you can look to see, are you a private payer? Are you looking to see that, we're seeing this a lot, people whose kids have come home from college and might have gone from college to a different state. Can they still access that healthcare from their provider in a different state? And it'll even tell you with the blue dot cross-state licensing and things like that. It's really, really easy to navigate. So I very highly encourage you to go to this site, play around a little bit, see what's happening in your state, the state that your kids might have previously lived in, or are planning to live in again, and see what's happening in telehealth in your particular state. Another thing that's interesting on this particular website is that it'll give you the status about when these particular statutes that provide telehealth coverage will expire. And what we are concerned about are these statuses that say active until the peacetime emergency is terminated. And the peacetime emergency that is being referenced is that public health emergency that we talked about a few slides ago that relaxed that HIPAA coverage. Why this is something that we should be paying attention to is that while there is no indication that the public health emergency will end anytime soon, because we are still really in the thick of dealing with this pandemic, I don't want to undersell that it can be ended at any time. And once that public health emergency is ended, there's nothing necessarily to keep these regulations that have been enacted to increase the access to telehealth that we have all been enjoying during the peacetime emergency still going. That said, there are opportunities for you to advocate as a parent and caregiver if you are finding that telehealth is something that you would like to see continue. I think a lot of us, when we are faced with these big structural issues, don't really know where to begin. And I am here to tell you that the most powerful thing that you can do as a parent and caregiver is share your story. Policymakers have the data. They, as Dr. Busa said, they've had this data for several years now that this is what patients want. But what really moves the needle are the appeals to emotion and being able to go to policymakers and say, there's this incredible story of this family in this particular state, and having telehealth has improved their lives in these, measurable ways. And if we can gather more stories like that and make that storytelling really powerful, what an amazing tool for advocacy that is. I want to encourage you, though, that even if you haven't had a good opportunity or good experience with telehealth, please still tell us your story. Because if this is not working out for you, the other thing that this particular survey that we are doing at CNF will help us learn is how we need to improve in this area. So in addition to giving us the powerful stories that we can go to policymakers with to improve telehealth, having the stories that show that this might not be working out as well as you want it to also then allows us to build the tools and resources for providers and families to improve this for all of us moving forward. The CNF and a lot of other patient advocacy organizations work with medical specialty societies, and one of those medical specialty societies is the American Academy of Neurology, who has an advocacy center. The easiest way to find it, honestly, is just Googling AAN Advocacy Center, and what you will see is a screen that looks similar to this. And I pulled up this Protect Telehealth coverage one specifically because that's what's most, I think, meaningful at this point to us in this particular conversation. But what the AAN Advocacy Center does generally is it pulls all of its legislative priorities and it finds your representatives for you. It gives you a template letter. It's a very low impact way to contact your representatives. I encourage you to spend some time on that, not just for the protection of telehealth coverage, but for the other legislative priorities that AAN has, because in a lot of ways, it's going to improve our outcomes as patients to make sure that the providers who give us our care are properly compensated and are given all the resources that they need to provide the best care for us. In addition, the AAN also has, Hill days and things like that every now and then. Something that they are trying new next week, July 28th through 29th, is an AAN Telehealth Day of Action. It will be virtual, and the goal is to develop a toolkit that will help you learn how to develop a template to write op-eds to your local news papers and post on, blogs and things like that, how to do social media blasts, as well as other virtual state and federal advocacy opportunities. This should be a really great experience and give you some advocacy tools moving forward. And if you would like more information, I encourage you to contact Derek Brandt, who is the legislative advocacy head at the AAN at dbrandt@aan.com. But just to wrap up, again, stories are so powerful. Caregivers, patients, and parents really need to understand how powerful they are by being vulnerable enough with us to share that story and share their experience. And I would really love if all of you could go to the childneurologyfoundation.org website. And if there's something will pop up on the website where you can click take survey, it'll take you there. And I think one of the things that we can all learn from this time is, I feel like we all are just so stressed out, so feeling like we're not really in control of anything. But this is something that we all can do. We can all work together to make sure that our children have increased and continued access to this tool that is really improving the lives of so many of our kids right now. And with that, I think we now have time for questions and discussion. Is that right?
So actually, thank you so much to all of you. That was fantastic. I am going to shift us over now. We have our caregiver who is going to share a little bit about their telehealth experience, excuse me. And so I'll just introduce her. Her name is Casey Craig. She is the mother to 4.5-year-old Stella, who has SCN8A related epilepsy and a number of, she's severely impacted like my kid, Elliot. And so she's had some experiences with telehealth, and we'd love to hear from you now, Casey, to hear about your experiences with telehealth.
Thank you. Yeah, we had never had telemedicine before COVID. And when COVID hit, we had about 5 doctor's appointments scheduled for the week of spring break, which was when all of COVID kind of came down. And so our neurologist called me personally. I'm typically the mom that's going to come to those appointments, hell or high water, right? And so she knew that I was most likely going to make it happen, even if I was a little nervous about it, right? And so she called me and said, "You're not coming." And I said, "Thank you. Thank you for making that choice for me." And she said, "This is what we're going to do." And so I was her very first telemedicine visit with Stella. And it really gave us a chance to chat and talk about COVID, right? What do we need to do to keep Stella safe? Do we have the rescue meds that we need? How do her seizures look like? What's her baseline right now? So we had all that conversation, over the phone at that point in time, because they didn't have Zoom quite ready to go. And so it put me at ease, being able to talk to her and getting some of that feedback right then and there. So just a little bit about our geographic area. We live in Southwest Missouri, and although we have 2 fairly big hospitals, Stella is so severe and special that we travel to St. Louis Children's Hospital, which is in St. Louis. So if you were just going to drive, me and you, without Stella, it would take us probably about 4 to 4.5 hours to get there. But with Stella, that equals at least a 5-hour drive. You can imagine all the things that we have to pack in one visit. We have our cough assist machine. We typically have to bring oxygen just in case, because if we don't bring it, we'll need it. Her suction machine, her nebulizer, and then all the things that she needs in order to sleep, things like that. So it is a lot, to the point where I have to put everything in the van and take a picture, usually, to figure out how to put it all back in the van when we come home. I work full time, as does my husband. And so when we make trips, we typically will schedule them for spring break or fall break, Christmas break, summer break. And we have multiple appointments on the same trip. So we try to see as many specialists as possible. All of our specialists are in St. Louis. We have our pediatrician back here, and then everything else is at St. Louis Children's. And so the last time I checked, I think we had about 15 specialists that we see. Some of them it's every 6 months. Some are only once a year, and then our neurologist is usually every 3 months. And so you can imagine, it just really adds up. And so a lot of times we're having to get a hotel room even because of all the appointments that we're going to. So we had our first appointment with our neurologist, which was great. And then since then, we've had one with nephrology. We had another one with our neurologist. We've seen ENT. We've seen our pulmonologist. So we were talking about her sleep study results. So she did have to go in for a sleep study. But what we found is that it has not only helped Stella's quality of life, because we're not on the road for 10 hours, but it's helped us. Like, I've been less stressed because taking that time to pack everything and to drive, and then we don't have night nursing whenever we're on the road, so then it's all me, and then by the time I get home, I'm exhausted. Also, right now with COVID, typically it's just one parent that can come. And so with telemedicine, it was me and my husband, and we both got to be available and talk to our neurologist. And so it's been really great for us. Knock on wood, Stella hasn't had a extreme illness at this point in time, though. Obviously, if she were sick or she needed someone to listen to her lungs, we would be going into the office, and I have no problem of saying, no, we're coming to you. But as far as a general, let's talk about sleep study results, or let's talk about some medication changes. What was nice about this last telemedicine visit was it wasn't even scheduled. It was one of those things. I had given her updates saying, okay, so the seizures are getting worse. Now we're up to 20 to 30 tonic seizures, real short ones. We've tried this medication change, but now the side effects, what are you thinking? And she said, hey, can you chat tomorrow at like 10? And I'm like, yeah. So we spent an hour and a half on telemedicine, and we were able to chat about 3 different type of medication changes. What do we want to do here? What's the pros and cons of each? Let's talk about, in the future, we might want to look in VNS. Here's the risk, here's the benefits. And so we had these really at-length conversations that we felt comfortable with because she's seen her for 4 years. So she knows Stella's baseline, she knows about her. And so we felt very comfortable having those intimate conversations about, big med changes or surgeries, things like that. So it's been a huge help for us. And her hope is that this is something that we can continue to do with Stella, especially with neurology, because we have such a close relationship of, checking in every 3 months. And maybe we see her every 6 months, or we see her once a year. Stella typically likes to visit her when she's in an airplane on the way to St. Louis instead of in the office. But if we can decrease those drive appointments and still keep Stella safe, it's been really life-changing for us.
Thank you so much, Casey. That's really, I think I think you cover all the ground with that about, the distance and the advantages of, so thank you so much. And I hope telemedicine is here to stay for you.
Me too.
Stella. Yeah. All right. I'm going to pass it over to Jayetta, who's going to run our Q&A. Just a reminder, if you have any questions, feel free to put them into the Q&A or the chat, and we'll be tracking those. I know we had a few questions come in via email in advance, so I think Jayetta will likely start with those.
Yes, thanks so much, Gabi, and thanks to all of you. What fabulous information, and really hopefully mobilizes and empowers us to speak up and really let family voices be heard. We don't have a lot of time. I'm going to have one question, I think, that will be for each of you. Dr. Busis, you heard from Casey about how important remote access for specialists is, that lots of families have been driving for hours to see specialists. And a lot of times it isn't their regular doctor, but their kids are so specialized that they need to do that. You talked about those 5 buckets at the beginning. With some of the reforms or advocacy that's underway, is that one of the forms that hopefully has a chance of surviving, so that it isn't just for access to your local doctor, but access to the kind of specialists that are required for a lot of these DEE kids with such severe and relatively unique and distinct forms of epilepsy?
Yes, I think that any kind of telehealth access is not just for your local person, it's for anybody that you can connect to. And I think that, Casey, I was really touched by your story, and I thought of the flip side of that, and that is that there's positive feedback. So you go to this person because they know her and her condition very well. By doing so, you allow that expert to become more expert.
Right.
If there are a relatively small number of kids that have what she has in the country, that person can see almost all of them, and therefore can get even more expertise. So it actually helps the physician to get a case study going and to get a feel for the spectrum of the illness, as well as the parents.
Terrific. That's encouraging, because I wasn't sure if that would be something that might be carved out in some of the initiatives to make this last beyond the COVID health emergency. Dr. Herman, I wanted to ask you, in your presentation, you talked about the fact that there was a real rollback already, that 50% of the centers are now doing less than 50% of their visits by telemedicine. And you talk about the major barrier being the uncertainty of compensation. Can you talk about what really needs to be done to resolve those institutional concerns, to preserve telemedicine? And are some of the advocacy proposals for either legislative or administrative changes really going to be adequate to persuade those administrators to roll back again and reopen this as the powerful option that it is for so many individuals and families?
I think that's going to really, as I mentioned, be the key driver. It is very, very time and resource intensive to do telemedicine. I mean, we basically had to bring in lots of IT experts. Our medical assistants spend a lot of time on the phone now with families that are not really digitally savvy, trying to get them on calls. The whole process of getting the kind of information that we usually collect before a visit, consent forms and privacy disclosures and check boxes of, you know, how your child has done since the last visit, are now much, much more difficult. Communication after the visit. How do I get you the visit summary? How do I make sure that you know, the prescription is done in a timely manner and that you have the instructions on how to give that medication? All of those things which traditionally are done by, you know, handing forms and papers to patients or from patients to providers needs to be redone. And I mentioned before that the solutions that most of the hospitals have turned to are not integrated with our electronic medical records. And so all of that is being done outside of the usual routes of care. And that's very, very expensive. It's very inefficient. And there are no real ways of compensating practices for all of the resources that they're pouring into this. You may be aware that many of the insurance companies have waived copays during the COVID emergency. But what you may not know is that the copays go to the physician offices. They don't go to the insurance company. So by waiving the copays, they basically cut all of our income by 20% right off the bat. In addition, the number of different plans and the different reimbursement and how you have to bill a phone visit for one company versus another company, even within the same state, is almost impossible to keep up with. I mean, our billing and coding person said at one point, I'm not sending out any bills for 2 weeks until we have some clarity on what we actually are going to do. You know, there are reimbursements for providing telehealth services, but it's not clear what those are for practices that are doing telehealth in the way that we're doing it right now. That would be if you had a telehealth center where patients would go and do their telehealth with somebody remotely, but they wouldn't be in their home. And what we're doing now in the home, I don't think that there's really a formula for how much it costs to do that. So there's a lot of uncertainty about what's being paid, what's going to be paid, when the payments will end, right? So we get all of this infrastructure in place and suddenly somebody says on July 31st, it's done. And we have to roll back and go back to in-person visits. And how do we do that? So I think really working on what the reimbursement structure is. In some ways, telehealth is less expensive, but in other ways, it's more expensive. It certainly requires more people and more resources. We had to buy webcams for every computer that we have in the hospital. We had to buy laptops for all of the staff who are working at home, and none of that is included in a clinic's budget. I'll stop there.
Well, can I do a quick follow-up? We know there are many forms of advocacy that are taking place at AAN, and a recent letter of 340 institutions with specific asks. Is this whole issue about the reimbursement structure really addressed in those, or do we need more granularity in the kind of reforms to really make it last?
Yeah, I think that there's going to be, there's a couple different things that need to be looked at. So one is, what's the type of televisit? Is it phone? Is it video, et cetera? And just making it much more straightforward than it is right now. The second is, how much does it actually cost a practice to be telemedicine ready? Not just for, the equipment, but also for the licensing of the providers, the training of the providers to deliver medicine in a completely different way. And I don't think those things have been worked out for the long haul. I mean, we didn't have a choice about doing telemedicine, right? It had to be done for public safety, for patient and family safety, but that's not going to fly for the long term. So we actually need to, drill down and do the type of, really careful cost analysis that CMS and insurance companies typically do when they're developing new codes. And Neil and I, Dr. Busis and I, have spent more time in coding rooms in the Centers for Medicare and Medicaid Services than we want to think about. But that process needs to be done for telehealth under normal, not under COVID circumstances.
Right. Terrific. Well, thank you. And Jessica, I have a question for you. You raised the question about how everything varies by state. And while you gave us a great link for information about different states that we'll make available on our website, I wonder if you could kind of revisit that issue and talk about how significant variations are in state laws and regulation and programs, and how they may remain and continue to be significant, even if some of the legislative reforms to continue to facilitate telehealth visits are enacted. So just tell us a little bit more about the significance of variation in states and how significant that might be, even overriding some of these efforts to preserve the telehealth option.
Sure, that's a really big question, and there's a lot more to it than I think what I'm going to say, but just in the interest of time and sort of an overview, I think that federal versus state policy thing is always going to be in tension in a lot of policies, but particularly in health policy. And when you're looking at telehealth, there's different levels of state and federal advocacy that need to happen. And so when you're looking at within a particular state, things that you might need to take to your state legislature could be coverage, could be increasing access. So like there's policies that are being floated around in some states of turning local libraries into sites of telehealth to address some of the equity and access issues that Dr. Herman raised. And so that's happening at a state level. Another thing that's happening kind of in that in-between level, though, is state licensure. And so where telehealth, I think, can be really complicated is that historically, physicians have had to have licenses in the states in which they practice. And if I am a patient, something that we're hearing a lot is this problem with people having to go home from college. And so there might have been a patient who went to school in Montana, but now has moved back home with their parents in Colorado because of COVID, but the relationship that they have built is with their adult provider in Montana. And can they still see that person, or is there going to have to be another transitions of care in place under this? And so that's kind of a long-winded way of saying there's multiple issues at multiple levels. And when we talk about state advocacy and when we talk about federal advocacy, there's a lot of overlap too. I mean, there could be a very like broad brush about federal licensure. I don't see that happening though. And I don't think realistically that's going to happen I mean, there's a lot of regulations that would have to get in place there. And I will say the public health emergency has relaxed a lot of those state licensure requirements. But it's still not a situation where you can see like any physician anywhere, no questions asked kind of thing. To that, I can only recommend that people get involved at the state level as well, know what's happening at your state, get involved with state neurology societies, local patient advocacy centers. Groups like the Epilepsy Foundation, for example, have local chapters. That's a really great way to be involved on something that's happening at a more local level. And they would be much more in tune to, if you're really interested in what's happening in Florida, and something about the way that healthcare is delivered in your state that the governor and the state legislature have a say over versus the Department of Health and Human Services or the U.S. Congress. So there's like also a lot of, it's hard to keep abreast of everything that needs to be learned. So I encourage people who are just starting in advocacy to lean on groups like Deep Connections, groups like the Child Neurology Foundation, to keep track of those for you. And then help, like groups like AAN who are doing this advocacy organization, can then take that labor off of you and say like, oh, in your state, this is what you need to do. This is the letter you need to write. This is what we need to say for this particular issue. Because for one individual family to keep track of what they need to go to the county for, what they need to go to the state for, what they need to go to the federal government for it's too much. It's too much to keep track of. And it's constantly evolving. So I don't know if that answers your question. But
I think it's very helpful to recognize that there is complexity and granularity for this, but I think you've all made such a compelling presentation about the impact that our families can have, that if in fact this is a resource that is making a difference, like Casey said, not only in the quality of her child's life, but her life, hours and hours of risk. I mean, I know my grandson is 10 minutes from the hospital, and he's often too sick to go to a hospital visit. And so he's getting more regular attention now than he was before. So I think what we really want to acknowledge and thank you all for is giving us not only the background of how complex this is, but how families can have such an impact by telling those stories. And those links that you provided, all of you, will be on our website, and we're going to continue to try to get more and more families speaking up, because we know this has just been terrific. We're running over time. Gabi, let me hand it over to you to wrap up.
Thank you so much. And just a huge thank you to our panelists today, really for showing us and telling us and giving us the details we need to know to better understand this situation, and really giving us some action items, which is really fantastic. And thank you for everyone who joined us live, and for those of you who are joining us on the recording, we're glad you found us. A quick note about other upcoming webinars we have in the next couple of weeks. This Wednesday, we have part 3 of our Rescue Meds for DEEs series, which is a really fantastic panel of caregivers sharing their experiences. And I think it'll really be incredible to watch and listen to. One on July 29th about autonomic dysfunction that we're doing in collaboration with our friends at Families SCN2A. And I'm really excited to watch this one, because I feel like autonomic dysfunction probably could explain a lot of the things that we don't have answers to, potentially. So tune in. And then August 12th, part 4 of our Rescue Med series, which will help families understand how to update or build their own seizure emergency plan. So I want to thank everybody again for joining us, and thank you again to Neurocrine for their support for this webinar. Take care, everyone, and we'll see you next time.